first year?
When, January.
No, yeah.
Yeah, the end of January.
Was it really?
Yeah.
You had 2 months then?
So I'm going to go ahead and start with a couple of announcements. So HIV rounds today, we will be providing CME credit to attendees today. So please complete the provided CME forms that are provided at your location. And please make sure you print clearly or you may not receive credit for attending. We're also happy to announce that we will be offering social work credit for today's presentation. If you haven't already, please sign in on the provided sign-in sheet at your location. Please make sure you print clearly or you may not receive your certificate. For social work, at the end of today's presentation, there will also be another document that you must sign attesting that you attended today's entire presentation. Social work credit's very strict. No partial credit can be given for partial attendance, and your certificates will be sent via email 2 weeks from today. So our topic today is HIV Hep C co-infection. Our speaker today is Dr. Brianna Norton. She is an assistant professor of medicine in the Division of General Internal Medicine and Infectious Diseases at Montefiore Medical Center, Albert Einstein College of Medicine. Her clinical work includes the treatment of HIV and Hep C in the primary care setting. She also conducts research to improve linkage to Hep C care and treatment uptake for people who use drugs. She's also the medical director of the New York Harm Reduction Educators, a syringe exchange program in East Harlem and the South Bronx. So please welcome our speaker today.
Hello, thank you, everybody. Let's see. Great. So I am going to talk about HIV Hep C co-infection and what's new in 2017. So as everybody knows, we have an epidemic of hepatitis C throughout the world and in the United States. And there are currently 4 to 5 million people living with Hep C here in this country, and it is now the #1 cause of end-stage liver disease, hepatocellular carcinoma, and also liver transplant. And this was a pivotal study that was published in the Annals of Internal Medicine showing that more people died of Hep C in 2013. I'm sorry, more people died of Hep C than HIV starting in 2007. The latest data from the CDC we have is that 19,000 people died of Hep C in the United States in 2014, although this is likely a very low estimate, given that our reporting is not great for hepatitis C in this country at this time. But more people died of Hep C in 2013 than from the top 60 other infectious diseases, including HIV, TB, and pneumonia. So it really is an epidemic that's causing a ton of mortality in our country. So HIV and Hep C, because of shared modes of transmission, are obviously sort of carry in the same groups of people. Currently, there are 10 million people worldwide who have Hep C HIV co-infection. 35% of U.S. patients with HIV have Hep C, and the outcomes of people who have co-infection are worse than for people who have Hep C mono-infection. So who has Hep C co-infection? So these are data from New York City, actually, from 2015. So what you can see is that, let's see, so basically this is all people living with HIV versus HIV Hep C co-infection. And essentially what we see is that there are more people who are Black or Hispanic, so in minority people of color populations living in New York City than people who are living with HIV alone, so 83% versus 78%. If we look at gender and age, the co-infected tend to be more men than women, and that nearly 73% of HIV co-infected individuals are above the age of 50 compared to only 50% of people living with HIV. So this is an older group of men in New York City who are often people of color, and if we look of where these people live, a lot of these people actually live in the Bronx, so not in Manhattan where we are right now. If you look at exposure category, what you can see is these bars are exposure category for people who are hepatitis C HIV co-infected, and the dots are just all people living with HIV. And obviously, MSM make up both of these groups, but really the predominance of exposure category for people who are HIV Hep C co-infection lies in people who use drugs or people who inject drugs. So over half of those HIV Hep C co-infected report a history of drug use, compared to only 15% in people living with HIV alone. Now, I think what's important to recognize is that, so in New York City, we have a population that really consists of IV drug users, but we are currently in Manhattan, and not necessarily all of our people who have HIV Hep C co-infected are going to mirror this group of people. So I do want to point out that for a long time, sexual risk was very confusing for Hep C, and for years we actually said that very few people obtained hepatitis C through sexual transmission. This changed actually with a CDC report that was published in 2011, showing that we started to see acute Hep C infections among HIV positive MSM. And when they looked at these group of people, epidemiologically, it seemed that these are the risk factors were people who are having condomless anal receptive sex, and also people who are using crystal meth in New York City. And importantly, when they looked at this group of people and did phylogenetic testing of the Hep C virus itself, they saw that the phylogenetic Hep C clustered within each other, and that virus cluster was actually different and unique than the clustering that was seen among people who inject drugs in New York City, really showing epidemiologically and genetically that this virus was being transmitted through sex. So these are our estimates of incidence. So incident is acute Hep C, so people who are newly converting among HIV positive MSM in our US cohorts. And overarchingly, we get usually a number of around 1.2, 1.3 per 100 person years. So in 1 year of 100 HIV positive MSM, we can expect 1 to new hepatitis C infections. Now, the max cohort you can see is a little bit lower, and that's really likely because a lot of that's a much older cohort of patients that we've been following for a long time. And what we've noticed is that our HIV Hep C co-infection patients who are HIV positive MSM tend to be getting their infections actually relatively recently. So let's take a little bit of a look at San Diego, because San Diego has a lot of people, over 2,000 people, and they really looked closely and recently at their HIV positive MSM population. So this is a study that was done and recently presented, and it looks at the incidence of infection of HIV positive MSM in San Diego between 2000 and 2015, so more recent population. So this is a group of people who go to the Owens HIV clinic. It's really probably the most populated HIV clinic in San Diego. This is about 2,395 patients, and all of them at least had one initial Hep C negative result within the clinic, and then had to have at least another HIV test so that they could actually look at new infections that were occurring. And this is just the population, who they represent. In San Diego, a lot of these people are white HIV positive MSM. And what you can see is that the people who report injection drug use, although it's not zero, it's quite low. So majority of these people are not injection drug users, they're HIV positive MSM. So after following these people over 15 years, what we saw is 149 new hepatitis C infections for an incident rate about 1.2 per 100 person years. And when they looked at when they did a regression analysis to see which factors were associated with acquiring a new Hep C infection, what they really saw was not related to age, race, but was related to drug use. And interestingly, meth only, so crystal meth unrelated to injection drug use, you were 3 times more likely to be an HIV positive MSM who acquired hepatitis C. Certainly injection drug use was a risk factor. But I think it's important to note that both epidemiologically in retrospective studies and in this study, that crystal meth use, probably likely a marker of high-risk sexual activity, seems to be a risk factor for acquiring Hep C. Importantly, we're seeing this in a lot of small cohorts now, and this, like I said, this was recently reported, is that the 1.2 per 100 person years risk of Hep C is actually increasing. So if you looked per 2000, 2003, that risk was a lot lower. And each subset of years, as we go forward, the risk of HIV positive MSM acquiring Hep C seems to be increasing. And we're hearing that a lot anecdotally, and more data is coming out to say that new incident Hep C infection among HIV positive MSM is a problem and is trending forward. So what about HIV negative MSM? So for a long time, what we've been talking really about is that this is a problem among HIV positive persons. But surprisingly, there was in the Amsterdam PrEP project, they saw a very high number of Hep C positive HIV negative MSM. So this is a project where in Amsterdam, where they have a public health system, they rolled out PrEP among their HIV negative MSM who were considered high risk for acquiring HIV. So these are not folks who are in monogamous relationships, but really HIV negative MSM who are having high risk sexual activity. They enrolled them in the PrEP project. There was about 400 of them enrolled. And what they saw is that right off the bat, there was a 4.8% positivity for Hep C, and 4% of those people were RNA positive, showing chronic Hep C. And this is about 2 times higher than the general population in Amsterdam, and certainly it's about double the prevalence in the United States as well. And when they looked at who these people were, they were more likely to be young, have a history of ST, have condomless anal receptive sex, and again, have some history of chemsex, meaning crystal meth while sexually active. Okay, so this is, we can see that our HIV Hep C co-infected patients are both a mix of HIV negative MSM and also people who inject drugs. But really, why should we specifically care about the HIV Hep C co-infected patients, say, versus the mono-infected patients? And really, that's because we know that the liver disease and the extent of fibrosis is much worse for HIV Hep C co-infected. So this is a study that was published a while ago, back in 2001. It's a meta-analysis looking at multiple studies and looking at the relative risk of acquiring cirrhosis or decompensated liver disease for HIV Hep C co-infected compared to Hep C mono-infected. And what you can see is that there was a 2 times a risk of developing cirrhosis and over a 6-time risk of having decompensated liver disease if you're HIV Hep C co-infected. Now the catch with this data is a lot of people said, yeah, but these data are really from the 80s and the early 90s, and that this is before highly active antiretroviral therapy, and that perhaps in the era where everyone's really well controlled on highly active antiviral therapy, that these relative risks will reduce in that setting. So this is another study published in 2008 looking at over 30 studies in the era prior to and after heart. And what you can see is that, again, this is the risk of getting cirrhosis in mono-infected versus HIV Hep C co-infected. The risk is much higher in developing cirrhosis among the co-infected. These authors then looked at the relative risk pre-heart and post-heart. And what you can see is that the risk does reduce, but it certainly does not go back to 1. And what we know very well now in following prospective cohorts of HIV Hep C co-infected is that indeed the risk of liver disease, cirrhosis, decompensation is higher among our HIV Hep C co-infected group. And there's a lot of reasons why they think that is. Certainly, there's been some hypotheses that this is epidemiologic, meaning is it risk factors, is it drug use? But there's also biological explanations for this, and that we know that both HIV and Hep C actually lead to increased reactive oxygen species in the hepatocytes and the stellate cells of the liver. These reactive oxygen species then induce protein productions that ultimately enter the nucleus and show expression of pro-fibrogenetic genes and actually inhibit anti-fibrogenetic genes. And so there are some really biological hypotheses of why co-infection is indeed leading to an increased risk of fibrosis. So this is a more recent study to show that indeed this is in prospective studies tends to be true. And this is a study in the VA system from 97 to 2010. So again, in the era of HAART. And this is a study of 10,000 people. There are over 5,000 people in both arms, meaning 5,000 people in the Hep C mono-infected and 5,000 people in the HIV Hep C co-infected who were indeed being treated with HAART and were virologically controlled. And basically what you can see, the years to hepatic decompensation is worse for the co-infected patients, and this is shown over and over. Okay, so we have a disease that is serious, that leads to poor outcomes. Can we actually successfully treat Hep C in our HIV Hep C co-infected patients? So the good news is we have great medications. They are all now 1 pill a day. We have Sofosbuvir, Ledipasvir, which everyone knows as Harvoni. We have Zepatier, which is again 1 pill a day, Elbasvir and Glecaprevir. And we have a new medication, Epclusa, which is Sofosbuvir and Velpatasvir. And all of these medications are 1 pill a day for 12 weeks and have great cure rates. So I can just briefly take you through some of the studies to show how they did in HIV Hep C co-infected. So these are the cure rates for 335 HIV Hep C patients who were placed on 12 weeks of Sofosbuvir Ledipasvir. And what you can see is that the overall cure rate was 96%, and this is in a large cohort of people, 335. And then whether you had cirrhosis or had treatment naive or were treatment experienced, your cure rates were all over 95%, and this is in an HIV Hep C co-infected cohort. So this is great news. Now, a lot of people say, yeah, but what about the side effects? This is to show you that, one, the side effects are very low. There were no serious side effects. No one's discontinuing medication because of treatment. And in all these studies, CD4 counts remain stable, and there are no HIV virologic rebound when on Hep C medications. Okay, so what were the side effects? So these are the side effects that were in greater than 5% of people. So actually that, side effects that are likely to be relevant and potentially related to the drug. And what you see is there are pretty minor side effects like headache, fatigue, potentially diarrhea, maybe nausea. And I can tell you from treating patients clinically, most patients will tell me they feel completely normal. And again, some people will have like a small headache or feel a little tired, but quite minimal. So Zepatier. The good news about Zepatier is that it's about half the cost of Harvoni. It's made by Merck. As a result, because it is about half the cost, a lot of our formularies, our insurance, our payers prefer Zepatier in our patients, and that's because it's about $54,000 compared to $95,000. So these are the cure rates in 218 HIV Hep C co-infected patients on 12 weeks of Zepatier, again 1 pill a day. And basically what you can see is the cure rates are wonderful. They're 96%. So really great cure rates. Again, side effects are low. We're talking maybe a little fatigue, maybe a little headache, but generally speaking, very well tolerated. And I think what's interesting is not in the HIV study, but in another study with Zepatier, what they did is they gave people placebo for 12 weeks. They then allowed them to go back onto the true med, and they did that to see actually the difference between side effects in people receiving placebo versus Zepatier. And I just want to show you that this is the side effects for people actually receiving drug, and these were the side effects for people receiving placebo. And pretty much what you can see, interestingly, although headache, nausea, and fatigue remain the highest, there's actually no difference between drug and placebo. And I think we just see that clinically in real life when we're treating our patients. Most people really do quite well. Okay, So this is Epclusa. Importantly, both Zepatier and Harvoni are for genotype 1 disease, which most of our patients have, but certainly we do have patients with genotype 2, 3, and a minority with 4. So the great news about Sofosbuvir, Velpatasvir, which is Epclusa, is that it is a pan-genotypic drug. These are cure rates in 104 HIV Hep C co-infected patients on this medication. And what you can see again is the cure rates are wonderful, all 95% or above, and no matter what genotype, 1, 2, 3, or 4. So this is really the standard of care now for patients with genotype 2 and 3. Because prior to this, genotypes 2 and 3 were receiving Sofosbuvir ribavirin, and still had quite a lot of side effects and often had to go on 24 weeks of treatment if they were in genotype 3. So now for our HIV co-infected patients for genotype 1, 2, or 3, we have 1 pill a day, 12 weeks. And again, the side effects are very minimal: fatigue, headache, potentially arthralgias. Okay, but what about in the real world? So these are all clinical trials. They have care coordinators, they have trial staff to help people do well. So a lot of people say, well, what happens in the real world when we give our HIV Hep C co-infected patients drug? So these are in blue. These are actually the trials that I just told you about. And again, these cure rates are wonderful. And let's compare it to the real world cohorts. These real world cohorts are a combination of academic centers, VA centers, but also community health centers, public health centers, both in the U.S. and throughout Europe. And what you can see, and there's pretty good numbers, 150 to 200, people are doing very well in the real world, achieving cure rates greater than 95%. So what's coming? So this was actually just presented at EASL in Amsterdam 3 days ago. This is a new next generation direct acting antiviral. It is called Glecaprevir and Pibrentasvir. People already started calling it just GP because it's so difficult to pronounce. And we had a lot of data actually in mono-infected patients. This is not FDA approved yet. The clinical trials are finished for the mono-infected, and until just a couple of days ago, we had no data on HIV Hep C co-infected patients. But this is essentially a NS5A inhibitor, which is which is also in Harvoni, Zepatier, as well as Epclusa. And this one has a protease inhibitor. So 2 drugs active against the Hep C virus, once daily dosing. And importantly, this drug is not metabolized by the kidneys, which makes it very important because you can give it in patients with kidney disease. So, like I said, up until yesterday, so most of the studies had been done in mono-infected patients. They looked at both 8 weeks and 12 weeks of this drug. And overall, whether you were given 8 weeks or 12 weeks, your cure rates were 99%. So potentially the first drug we can start giving 8 weeks of therapy to. Unfortunately, in these trials, there's only about 15 HIV co-infected patients, but you can see they did well, even though there was very few of them. In terms of what HIV medications people were given. In this study, people were given raltegravir, dolutegravir, or rilpivirine, plus an NRTI background. And when they look at biosafety data, you can give Genvoya or Triumec with this new drug. So there's a lot of HIV medications that are compatible with this, and I'll get into that a little bit later. Okay, so this is the Expedition 2 study just presented a couple days ago, and what they wanted to do is look at more than 15 people in the HIV Hep C co-infected population. So they gave either 8 weeks of the drug or for people without cirrhosis, and they gave 12 weeks for the drug with people with cirrhosis. But just a caveat, there was only 16 people in the cirrhosis group. So these are primarily people who do not have cirrhosis, who are HIV Hep C co-infected. Again, what you can look at is they were given raltegravir, dolutegravir, or rilpivirine with an NRTI backbone. And basically the results of the study, if you look at SVR12, which is cure rates, so the cure rates for this study was 99%, whether you were in the 8-week arm or the 12-week arm. There was basically only one failure. So 100% of patients in the 8-week arm, so these were HIV Hep C co-infected patients on 8 weeks of 1 pill a day, 100% of them were cured. In the cirrhosis arm with 12 weeks, we had 1 failure, but again, that was only 16 patients. But I think what we're going to see is that very soon we can offer 8 weeks of treatment for our HIV Hep C co-infected patients. This is another drug that is in the pipeline, and it is Sofosbuvir, Velpatasvir, Voxilaprevir. But it's a 3-drug regimen, our first 3-drug regimen, and it's done really well in all of the studies, particularly in people who have failed current direct-acting antivirals. So if you failed Harvoni, say, and you then take this drug, you have cure rates that are 96%. Also, genotype 3 in the last, since our DAAs have not done so well. And in this study, they looked at genotype 3 cirrhotics. And if you looked at it for 8 weeks, for 110 genotype 3 cirrhotics, the cure rates were 96%. So this is going to be another new 1 pill, 12 weeks, 8 weeks that does very well. The problem or the caveat for us is that they have not tested this in the HIV Hep C co-infected patients yet. So whether the FDA gives a label for HIV Hep C co-infection, I'm not sure. Whereas in this drug, they have done these testing, and so when they get the FDA label, it will be appropriate to give to our HIV Hep C co-infected patients. Okay. Yes. All right. So we can cure these patients, but what about all the drug-drug interactions? Are we going to have to take all of our patients off their HIV meds or change their meds? So let's talk a little bit about what that entails. So this is a checkerboard of the Hep C medications. And these are the HIV medications, okay? And this, what you can see, this is Sofosbuvir, Velpatasvir, Epclusa. This is Zepatier. This is Vicarepac. And this is Declatasvir, Sofosbuvir, Harvoni, and Simsoft, which most people aren't using anymore. So the green is essentially there's no clinically relevant interactions. And what you can pretty much see is that for the integrase inhibitors, if your patient's on an integrase inhibitor, they're good to go. Every Hep C medication is okay for integrase inhibitors. The yellow is where it might require some monitoring, and the red is do not administer. And that's really the red and also the orange. So let's look at our let's look at our boosted protease inhibitors. That's really where most of the problem lies, okay? So you are able to give Atazanavir with the Vicarepac. However, you have to remember a couple of things. One, you cannot give ritonavir with that Atazanavir because ritonavir is actually within the Vicarepac. A lot of people are not giving this medication anymore because it's so many pills a day and we have other options. Unfortunately, with our other medications, Zepatier, the new drug that's 1 pill a day that's cheaper and that does well, you cannot give boosted protease inhibitors at all. What about Harvoni or Epclusa? And I'm going to show you those data. The problem with those is that when you give a boosted protease inhibitor with a tenofovir backbone, with these Hep C drugs, the tenofovir levels rise quite high, and there is a chance of renal dysfunction while on medication. And so we'll talk about why that is and what's been shown in the real world. So those really require either the ASALD guidelines say do not give these medications with people who are on boosted PIs and tenofovir. However, a lot of people in real life are giving these meds and monitoring the creatinines while on medication, and we can talk about that. TAF is a new medication that's out that you may or may not be switching a lot of your patients to. And so all of these medications actually do well with TAF, so it's really tenofovir that is the problem and not TAF. So if your patients are on TAF, you're okay. So again, boosted PIs are the problem. Also, cobicistat. Most of these medications cannot be given with cobicistat. Again, a bit of a problem. Okay, so if you look at it, basically Harvoni, all HIV meds except Stribold, and then the boosted PIs with tenofovir, you can only give if the creatinine clearance is greater than 60, and then you have to monitor GFR. For Zepatier, the integrase inhibitors are wonderful with an NRTI backbone, and then you can give rilpivirine. And for Epclusa, it's the same as Harvoni, except for you actually cannot give efavirenz or etravirine because it reduces the Velpatasvir in Epclusa. So there definitely are some problems. And so you have to really think about which HIV medications your patient is on before starting a Hep C med. I will tell you that the good news is that I can often, even if the insurance company, Medicaid, prefers, say, one medication over the other, if I write a letter stating why they might need to be on a different medication because of HIV meds, then I'm almost always able to get the Hep C medication that I want based on drug-drug interactions. So what is the problem with these boosted PIs and the tenofovir? So this is with Sofosbuvir, Ledipasvir, or Harvoni, okay? And this is tenofovir levels on the side. And what you can see, these are all HIV medications. In all situations, tenofovir levels will rise a little bit, but the problem is really with our boosted PIs, that they end up rising a little bit higher than we would like or than is expected. And again, if you look at TAF, tenofovir levels, even the metabolized tenofovir levels are extremely low and are not a problem if your patient is on TAF. This is with, and so that's Harvoni, this is Sofosbuvir, Velpatasvir, or the new Epclusa drug, and the same thing. We see that tenofovir levels are higher in most of these medications, but most problematic are with your boosted PIs and tenofovir with this medication. So the question is, what is happening in real life? So despite that, people are actually using these medications in real life to cure Hep C. And so this is a study actually out of the VA of HIV Hep C national cohort clinical case. And what they looked at, it was the creatinine levels for people on a boosted PI and tenofovir versus people on tenofovir and no PI versus no tenofovir. And they watched them through their Hep C treatment. And what you can see is the change in creatinine was completely the same. So in real life, though we see these tenofovir levels in pharmacologic data, in terms of delta creatinine in real life, it does not seem to necessarily be a problem. Then this is the Sofosbuvir Velpatasvir. This is the Astral study where they gave HIV Hep C co-infected patients Epclusa. And again, the expectation that was that the tenofovir levels would rise for people on a boosted PI and tenofovir. But if you look, so this green here is a non-boosted tenofovir. This is people who are on boosted PI and tenofovir, and this is non-tenofovir containing regimens. And this is the mean creatinine clearance at baseline and throughout all of treatment. And you can see there is no bump in creatinine clearance. And then again, they looked at the Cmax and Cmin for these, and changing creatinine does not actually seem to be a problem in real life when people are receiving these medications. So what do we do? So most people would say that do not give a boosted PI tenofovir regimen with Epclusa or Harvoni if your GFR is less than 60. But if your GFR is greater than 60, you can give these medications and just monitor the GFI throughout at week 2, 4, 8, and 12, and you're likely not to see a change in creatinine that is clinically significant. Okay, so what about hard-to-treat populations? So what about people who inject drugs? How are they doing on these medications? We do have a subset of our HIV co-infected patients who are drug users. So again, to show you the New York City data, most, there's a large proportion of our HIV Hep C co-infected patients who state that they do indeed inject drugs. And 1 in 10 new HIV diagnoses are among people who inject drugs. And approximately 80% of people with HIV who inject drugs also have Hep C. So this is certainly a big problem in our co-infected population. These are data between 2007 and 2012 to show the changing incident rate of Hep C. And what you can see is that between 2007 and 2012, there's been a 50% increase in new Hep C infections in the United States. And in 17 states, these ones in red, there's been a greater than 200% increase in acute Hep C infection. And most of these, greater than 70% of these infections are in people who inject drugs. So this is a big problem, and really our continued transmission is primarily seen in injection drug users, so we have to think about treating this population. So most clinical trials completely ignored people who inject drugs. The pharmaceutical companies obviously don't want people who are hard to treat. They don't want them messing up their data, so they excluded them out of their trials. You know, unfortunately, since Hep C tends to be a disease of people who inject drugs, this was not particularly beneficial for this population. Merck, thank goodness, came about and decided to do a trial with Elbasvir, Glecaprevir, which is Zepatier, 1 pill a day, specifically in people who inject drugs. So they enrolled people out of opioid agonist treatment centers, so methadone clinics, and they enrolled them into this trial. And like their other trials, they gave people drug for 12 weeks, and then they gave placebo just to see the side effects differential, and then they gave them drug as well. Now, unfortunately, only 8% of these people were HIV Hep C co-infected, but I'd just like to show you that despite being people who inject drugs, their cure rates were identical to other populations, 96, 95% cure rates whether you had cirrhosis or not, wonderful cure rates whether your drug screen while getting Hep C treatment was negative or positive. And what you can see, most people had baseline and throughout Hep C treatment, positive urine drug screens. Despite that, their cure rates were just as good as people who had negative drug screens. So this is certainly proof of concept that giving people who use drugs in methadone clinics, they do great. Again, people say, yeah, but that's in clinical trials. There's study staff. There's people watching them. Are there any data to show that in real life, people who inject drugs can do well? So I wanted to show you some data actually from our clinic, which is a federally qualified health center in the Bronx. It's in the South Bronx. We treat a very underserved community that's really been devastated by drug use, opioid use, HIV, and Hep C. And what's great about treating patients with Hep C in a federally qualified health center is that we do have an integrated model of care. So we have Suboxone treatment on site, HIV treatment, we have substance abuse counselors, mental health counselors, et cetera. So between January 2014 and August 2015, we evaluated 121 patients for Hep C. Almost 90 of them initiated treatment, and 85 of them were cured. So that was a 96% cure rate in the South Bronx at a federally qualified health center. If you look who these people are, these are people who 91% are on public insurance. We had 52%, so over half were people who use drugs. A quarter of them were HIV Hep C co-infected, and so people pretty much were what we traditionally would call difficult to treat populations, yet they were being treated in the community-based clinic. And importantly, when we look at the cure rates for people who use drugs versus people who didn't use drugs in this primary care setting, we can see that whether you are a drug user or not, your cure rates were identical. So there is some, and more real-world data will start to be published to show that both in opioid agonist treatment settings, in syringe exchange programs, and in community-based clinics, people who use drugs are still doing well on these 1 pill a day treatments. Okay, but what does SVR really mean? Essentially, I'm giving you data that is really laboratory data. I'm telling you that 12 weeks after treatment, their virus is negative in their blood. But does that have anything to do with clinical outcomes? Do people do okay? Do they do better? So these are data from a large study of HIV Hep C co-infected patients, 695 patients they followed, and they looked at people who were cured versus not cured of hepatitis C. And what you can see is liver-related events were improved if you were cured. Liver decompensation was less if you were cured. But importantly, overall mortality was reduced if you were cured of Hep C. And we've seen this now and also in multiple mono-infected cohorts, both in prospective studies and also in huge retrospective studies in the VA because they follow tens of thousands of patients. This is also a study that was just published in 2015. This is a meta-analysis looking at 31 studies that published mortality data on people who were cured versus not cured. And you can see in the general cohort, if you obtained SVR, which is this, that your mortality was reduced, that if you obtained SVR, even if you were cirrhotic, and I will emphasize this, and that multiple cohorts have been following people with F3, so advanced fibrosis or cirrhosis, And even in cirrhotic patients, if you're cured of Hep C, your mortality is definitely reduced. And then they took out the subset of patients who are co-infected. And indeed, if you are HIV Hep C co-infected and you are cured of Hep C, your mortality is reduced. So these are great clinical outcomes to show that SVR does indeed lead to improved health. Okay, but can you even get these medications? And let me show you some data about this. So this was actually originally published in 2014 to show that there were a ton of restrictions, and these are Medicaid data, so this is Medicaid in every state, tons of restriction based on what fibrosis level you had. Importantly, new data were published in 2016 to show that actually more states are reducing their restrictions on fibrosis level restrictions. However, the truth of the matter, 75% of states still require F3 or cirrhosis in order to get these medications. Importantly, what you'll see in 2014, we were here in New York, and we did have these restrictions, and in 2016, those restrictions were taken away. What's been great about New York is that no matter what, even back in 2014, if you had an HIV Hep C co-infected patients, you were supposed to be able to get medications despite liver fibrosis. And I will say in my practice, although I do have a ton of Medicaid patients, we really don't have much trouble with managed Medicaid or straight Medicaid and getting any of these patients' medications at this time. Again, there is sometimes a preferential for one medication over the other. For instance, Zepatier versus Harvoni because of the pricing, which is understandable. Since the cure rates are just as good, there's no problem using a drug that costs half the price. And if I do have problems, or if I particularly like to use one med over another because of drug-drug interactions, I just send in a letter, and again, I've had very little trouble. The problem I've actually mostly had is with private insurance companies, and I think that's going to continue to be a struggle. The good news is that with more and more of these medications coming out, there at least is some market competition, and so most of these prices will be driven down. Okay, but what about drug use? So drug use was also a very huge problem. So again, in 2014, tons of states, but not New York, thank goodness, restricted anyone from getting these drugs if their urine toxicology was positive. Again, a lot of these states have improved their restrictions. However, as of now, 71% of states have restrictions related to drug use. And some of them are even, you have to follow these patients for 6 months and get monthly drug tests on them in order to treat them for a disease that leads to death and cancer. So extremely discriminatory practices. But unfortunately, again, we live in New York State, and so this should not be a problem. Medicaid and managed Medicaid should not ask for drug use or information or urine toxicology information. Okay, but the reason a lot of these states are doing this is because they're concerned about reinfection. So is this all for naught if we treat our co-infected patients and everyone just goes and gets reinfected if we wasted a ton of money? Okay, so these are data presented in Annals of Internal Medicine in 2016, and they looked at people with a history of injecting drug use, currently injecting drug use, or on opioid substitution therapy, because a lot of the concern about reinfection has been in people who use drugs. And what you can see is the rate of reinfection per 100 person years is very tiny with people who have a history of injection drug use. That does go up if you currently are injecting drugs, but it's actually still pretty small, around 5 per 100 person years. So again, not a large amount that a lot of people have been concerned about. And again, in people in OST, again, around 5 per 100 person years is what we've been saying is the reinfection rate for people who inject drugs or use drugs who get treated for Hep C. Now, some of the criticisms of these data is that a lot of these data were from the interferon era. And when people who make it through interferon treatment, as we all know, which is super difficult, is long, with a ton of side effects, that this really narrowed in on a very particular group of people, and that once they make it through the 6 months of interferon, that they may not actually go back to injecting drugs, or this is a very specific type of person. But if we give 1 pill a day to tons of people, that maybe we'll see more reinfection rates than we have seen previously. But as of now, the reinfection rates we were saying are about 5 per 100 person years. So these are a little bit more current data, and this is a meta-analysis that was published in CID in 2006. And what they looked at is, okay, not everyone's the same. There are people who are low risk. There are people who are high risk. They define that as current injection drug users. And then they wanted to look specifically at HIV Hep C co-infected patients for reinfection. So these people had a 5-year recurrence risk of like practically 0 if you were low risk, and that was about 0.9 per 100 person years. If you were high risk, you had a 5-year recurrent risk of about 10%, which really is about 2.2 per 100 person years. So not much different than the 2 to 5 per 100 person years we were seeing previously. But the HIV Hep C co-infected people, we saw, again, not a ton of reinfections, but higher than even the high risk. And a lot of the reinfection that we're seeing actually in the HIV co-infected patients has been driven by the MSM population. So despite a lot of concerns about injection drug use, what we have seen is a reinfection rate of among HIV positive MSM throughout Europe, who has done most of these data collections, that are much higher than in previous studies. So this is Western Europe, and you can see that the range is from 7 to even 21 reinfections per 100 person years. The average is about 7.7, but these incident rates are higher than we anticipated and higher than in other populations. We didn't actually have a ton of data about HIV positive MSM in the United States until recently, until CROI of this year. So again, these are incident rates per 100 person years. Amsterdam, although the confidence interval is large, reports even as high as a 15 per 100 person years. London 9.6, Europe in general, I said, is about 7.8. Now, I showed you in the beginning of this talk that San Diego has been trying to follow their HIV positive MSM quite extensively, and that's when they published data recently on their infection rates. And they also looked at reinfection rates, and what we saw in the San Diego was about 2.9 per 100 person years. But again, this is a small cohort, about 400 people, so we're really going to be looking forward to seeing more and more what these reinfection rates among HIV positive MSM end up being. I think what's important to remember that if we look at reinfection as a reason to not treat, we really miss out on a huge opportunity of treatment as prevention. And we know that in HIV, treatment as prevention works, and although we haven't necessarily proved it with data with Hep C, we certainly can look at modeling studies, and this is a modeling study to show if we treat Hep C infection among people who inject drugs, if we just scale up to 80 per 1,000 people who inject drugs annually, we can drop the prevalence rate of Hep C dramatically. And if we don't do anything, we aren't able to reduce transmission. So in some way, treating the folks that are currently the cause of reinfection means we're treating the people who are transmitting disease. And the more we can get to those folks, then the more we can potentially prevent continued transmission and reduce the prevalence within the population. So I actually wanted to show you some data, real-life data, in treatment as prevention in a HIV-positive MSM cohort. So Netherlands is a very different health system than we do. It's public health, and they follow their HIV-positive people very closely. So there is about 20 clinics of HIV-positive people. That's where all the care is delivered in the Netherlands, so they know these people very well. So if you look, so these are data, and so as of 2015, Hep C treatment and medication access became unrestricted in the Netherlands. So prior to 2015, you had to treat people with interferon. After 2015, DAA treatment became unrestricted in the Netherlands, and everyone was able to get access. So out of 1,420 people in care. There was about 1,171 of those people were initiated treatment. Almost all of them completed treatment, and 70% of them, more than that, and nearly 90% of them achieved cure. Most of the people who did not achieve cure, this 173, were unsuccessfully treated with interferon. And I think one thing to point out is that the pink is people who were treated with pegylated interferon, and these data are from 2000 to 2017. So 598 people were treated with interferon from 2000 to 2015, 15 years. And then once DAA access became unrestricted in Netherlands, 573, so pretty much the same amount of people were treated in 2 years. So in 2 years, the same amount of people were treated than in 15 years previously with unrestricted access to DAA. Importantly, because of this, right now, 70% of all HIV positive people who have Hep C in the Netherlands are currently cured of disease. So that's a pretty, phenomenal achievement. As you can see, there's not as many of them as there is in the United States. It's a much smaller country, but when 70% of those people are treated, you have reduced the prevalence within a cohort that is transmitting disease pretty tremendously. So what they wanted to see was, did treating 70% of these people who are primarily MSM transmitting disease, does that reduce transmission rate? So in 2014, they had 93 new Hep C infections among these people, and this was about a 1.1% year incident rate of Hep C among this population. In 2016, so this is 2014 before DAAs were unrestricted and before the significant number of people were treated. Oh, we're on the last slide. So in 2014, there was only 1.1% per year, and in 2016, that was 0.55% per year, so a significantly less number of incident Hep C infections. And one thing they looked at, just to let you know, is they said maybe they're just not having sex. So they looked at the STI rates. Gonorrhea, syphilis, chlamydia all had gone up between 2014 and 2016, yet Hep C rates had halved. And so they really show, this is the first study to show that treatment as prevention can truly work. So take-home points. Both MSM and PWID make up our Hep C co-infected epidemic. Hep C leads to worsening liver outcomes, and therefore we must aggressively treat people who are Hep C HIV co-infected. This treatment actually leads to cure and reduce mortality. Drug-drug interactions are a nuisance, but they certainly are manageable. We're getting more drugs down the pipeline to diversify our choices. And again, treatment reduces mortality and can lead to prevention. Thank you.
Great. Thank you so much. And I'm so glad you were in Amsterdam so you could give us like really updated information. So that's great. So we're going to open up for questions. And so I'm going to start with St. Luke's, if there's any questions up there. Everybody, if you can unmute your mics. I don't know if St. Luke's can unmute their mic since they're in the room. I feel like Chris is trying to say something to me, but I don't hear him. Has everybody unmuted their mics? So I'll just start with 275 because I see somebody raising their hand while Chris goes to see what's going on with their sound. Okay, 275?
Yes. Yeah, hi. Thank you for your talk. That was really enlightening.
If you can speak up just a little louder.
Yes, I said thank you. Thank you for your talk. It was very enlightening. Do you think we are capable or we have an obligation to really bring down the price of these drugs now that we have a few options? I mean, is there any plan, comprehensive plan of really bringing the cost down radically?
Well, there is certainly there's a pretty big political effort among people who inject drugs through activist organizations like Vocal, who have gone up to Albany and protested, who have gone to DC and protested. I've been part of those groups. Whether that has any impact, it's hard to say. We certainly have gone and lobbied for it. Unfortunately, in the U.S., what has been the big thing is the market. And so we do anticipate with more meds coming out, particularly from different, before it was Gilead, they had the whole market. And once Zepatier came out with Merck, they were able to lower the drug by 50%. The newest drug that's going to come out is AbbVie. So, we'll anticipate hopefully them bringing the price down. I agree. I will say insurance companies have done some negotiating to actually get the prices down for them, which has helped access through insurance. It's just a really huge problem. Middle-income countries have done a much better job, and in Egypt, the price of treatment is now something like $30.
And I should mention that the groups like Vocal and Housing Works are helping to coordinate some Hep C Elimination Summit listening sessions around the state. I would really strongly encourage that it not just be a full room of activists,
yes,
but that there's medical providers in those rooms, because you guys can provide stories about some of the challenges that you have. They have not announced the listening session for New York City. They're mainly promoting the ones upstate. So once those are announced, we'll be sure to send those out on our listserv. So look for an email from Tristan. So we're about to run out of time. It looks like Dr. Urbina has a question, and I'll have to close after that one.
Okay, Dr. Norton, great talk. Thank you so much. Just a couple quick questions. One is, what do you think about treating during acute Hep C? And then the second is, which patients do you need to do this ongoing monitoring for HCC, hepatocellular carcinoma?
Okay, I'm going to answer the second one first because it's easier. So hepatologists are very, concerned that primary care folks, ID folks aren't going to do that. But everyone essentially who has cirrhosis should continue to be monitored for HCC throughout their life, like you would whether they're cured or not. I can say that even if you have cirrhosis, we know your risk of hepatocellular carcinoma is much reduced with SVR and Hep C cure, but that reduction in risk does not go to zero. And so we have to continue to screen them either with MRI or ultrasound, depending what your institution prefers. The acute infection is a little bit controversial. I'll say there are many people who are acute Hep C researchers who believe that we must be treating acute Hep C immediately for risk, because there are some people who have rapid progression into fibrosis, and also because of transmission rate. I think it's difficult when we live in a country where these meds are so difficult, and that 20% of these people might not go on to have active disease. Certainly having HIV co-infection, your risk actually of getting chronic infection is higher than people who are of mono-infection. I currently am not treating acute infection, but I think there's be a lot of people who would beg to differ with me. I think it's more of a financial thing.
Great. Thank you very much.
Thank you very much.
Sorry, we're running out of time. If folks have other questions, if you want to reach out to me, Terry Wilder, we can get you Dr. Norton's contact information. So anyway, thank you. We just have another group
Thank you. Sorry,
behind us. Thanks.
Thank you. Yeah.